Hi.
Good morning.
Good morning. Nice to see you.
Likewise. Okay, so I looked, you can see all my head before I joined. Can you see all my
I
head
can
now?
see your whole head. I can see your face. I can see all of you. You look amazing.
That's too
Okay,
much. That's too
fine,
much.
not all of you, but I see really good parts. So that's fantastic. That's all that really matters. Anyway, thank you for joining us on this beautiful Wednesday morning in December. We are so grateful to have you on. For those of you who are joining, hi everybody. I'm Melissa Oliveira. I'm the co-founder of HotPause Health, and we are joined this morning by the amazing, wonderful, and brilliant Dr. O'Sullivan, who is in Portland, Oregon. And I was going to start with a little bio on you because you're so impressive. Do you care?
No, thanks, Melissa. That's
Okay.
lovely.
Okay, I'm going to do it. So, Dr. O'Sullivan has been practicing medicine for over 30 years, which in and of itself is ridiculous and impressive. But she's a board certified family physician. And in addition to that, she has her certification from the Menopause Society. So she's a certified menopause practitioner, which is a really big deal. And we're going to talk about that actually throughout the whole day right now. And she has a practice that's focused completely on women's health, which again, for those of us at HotPause Health, is really, really kind of the whole point of this this kind of mandate that we're on. So perimenopause and menopause is what you focus on. And I think the two things that really, and again, these are questions that we're going to talk about today, is that you have robust experience in both hormonal treatments, but also non-hormonal treatments for those patients who either have contraindications or otherwise that really want to explore both options or, together, just depends on what they're looking for. So we're so grateful. And for those of you, by the way, who are in Oregon, Washington, or Connecticut, right? Dr. O'Sullivan has a telehealth practice called the Portland Menopause Doc. And so she can see any of patients in those states. So anyway, with that, I will stop talking because I'm so grateful that you're here.
Thanks for that lovely intro, Melissa. Yeah, we start medical school very early in Ireland. We go straight from high school. So I had just turned 19 when I started medical school. So that
Wow.
was 30 years ago. Yeah.
We're not doing the math on that because you're still 27. So
Oh,
we're going to
totally.
roll with
Yeah.
that. 100%.
Yeah.
Well, today's forum is a little bit different than other forums. And the reason why is we crowdsourced from our community, from our audiences, some of the questions that women have. And what we really want to dig into today are some of the myths. I mean, you could say myths, but I think there's so much misinformation right now, particularly for women who are going through perimenopause and menopause and saying, what's real? What's not real? How do I take this information and make a really informed decision? Because I want to make an informed decision. But what information can I trust and what information just isn't trustworthy? And so I think today, just given your perspective and experience and your knowledge of women's health in perimenopause and menopause, how do we help empower these women with information so they go in and be like, yeah, that's not true. Sorry about that. Busted. And so there are a handful of questions that we crowdsourced from our community, and I thought we could just dive in.
Absolutely.
That's okay.
Let's do it.
Okay, let's do it. So first question, and I have the same question, so maybe I'm biased. How do I know that I'm in perimenopause, Dr. O'Sullivan?
Usually when I'm giving a talk, I'll make a joke and say it's when you realize you have tweezers in the car, tweezers in the purse, tweezers in every room.
Why? What part?
We start to get these little hairs on our chin.
Yeah.
So, and then the other one is, feeling homicidal feelings towards your spouse for absolutely no reason.
Mm-hmm.
So they are two kind of red flags that it's perimenopause. But really, if in general, what I was taught about women who were going into menopause, it was all based on periods. And that is just very, very outdated. And if we go by that, we will miss so many women. We will gaslight so many women, not meaning to, but it'll feel like that to them.
That's right.
if we just go by periods. So I'm so done with that. You know, there was something called the Straw 10 criteria created to help differentiate for research purposes
Interesting.
how to categorize women whether or not they were menopausal, you know, because some women have the IUD in, they're not having any periods.
That's
Some
right.
women have had a hysterectomy, they're not having any
Right.
periods, you know, so, but yet they're not 51, which is the average age of menopause in America,
Right.
you know. So they came up with this criteria, and one of the things they used was a woman's cycle and what was going on with her periods. Were they getting spaced out? Were they getting shorter? Were they getting
Right.
heavier, lighter? And that was a good way to tell if someone was going into menopause. And I feel like a lot of doctors have latched onto that,
Right.
and it's now become a barrier to care for a lot of women
Yeah.
because it's so much more complicated than that. You know, the first thing that tends to drop during perimenopause, and perimenopause, for anyone listening, is when you are, you know, we are born with a certain number of
Right.
eggs, maybe 1, 2 million eggs. And even by the time we get to 12-ish, when we start to have our periods, we're down to about 250,000.
Right.
And we use up, you know, hundreds and thousands of eggs each month just getting
One
one to
little egg
release.
down the chute. Yep.
Yeah.
Yep.
And so, you know, by the time we're coming to our late 30s, definitely 40s, our egg supply is really quite
Mm-hmm.
low. And that's when and you know, it's the egg coming to the surface and all that process that actually causes the creation of our estrogen and progesterone. And
Right.
so when you're no longer having that lovely cycle, even though you might still be having regular periods, it's funny the way our bodies
Yeah.
work. You're not getting those lovely waves of estrogen and progesterone, and
Yeah.
instead it looks like these
Chaos.
big, yeah, chaos. Exactly. Dr. Mary
All
Claire Haber calls it the
the
zone
time.
of chaos. Yeah.
Zone of chaos.
And that
Exactly.
is what it feels like. And so our body doesn't do well when our hormones are up
Yeah.
and down and up and down, or when they're very low. And one of the first hormones to drop during that process is progesterone. And for most women, that will affect their brain. And the symptoms that they'll come in complaining of are they cannot get to sleep,
Yep.
and they have this either worsening anxiety or new anxiety.
Yep.
And it'll be funny stuff. Like it'll be, you know, I can't drive over bridges anymore, or I don't
Yep.
want to drive on the highway,
Yep.
or I wake up in the middle of the night worrying that something's going to happen to my
Yeah. You're
kids.
spinning.
Yeah, exactly. Yeah. Catastrophizing all the time.
Yep.
And so that is because our brain needs and loves progesterone, and progesterone acts on our GABA receptors in the brain. In the brain, it gets converted to another chemical called allopregnanolone, which acts directly on GABA receptors, which is just like what Xanax acts on, or, you know,
Yeah.
Ativan. So you can imagine then if those are usually saturated with allopregnanolone, keeping you nice and chill,
Right.
and now there isn't any,
Right.
then you get the symptoms of anxiety and women can't get to sleep.
Yep.
And so those are the things that I see most commonly. And then, you know, the next thing to start to drop for most women will be their estrogen. And then you get all these other symptoms. So for nighttime sleep, that usually means wake ups in the middle of the night.
Yeah. 2 a.m.
Oh, yeah.
2 a.m. to 4 a.m. That
Yeah.
one. It's
It's
a good time to be
awful.
up.
It's
It's
awful.
brutal.
And it's so funny how you actually become accustomed to it and you get used to it and you
Right.
rationalize it. And then if we can actually fix it, when you look back, you realize what a terrible effect it had on you. You just have no energy the next day. You're craving sugar.
Yep.
Your
Well,
appetite
it's almost
changes.
for me, the equivocation was when I was pregnant and then subsequently with a newborn baby. And you feel like you're in this fog of war where you can't think, you can't do anything, you're forgetful, you just can't process in the way that your brain used to. And it's that similar hormonal, zone of chaos of
Totally.
postpartum and then in perimenopause.
Yeah.
So it sounds like, how do I know that I'm in perimenopause? You're going to have symptoms that range from massive amounts of chin hair, if you're me, to anxiety and insomnia and, a lot of things in between.
Yeah.
So it's not just about your cycle.
It's not about your cycle at all. I don't care what your cycle is, because I feel like when we get stuck on things like this, especially as healthcare
Right.
clinicians, we you can have blinkers on, and it's so dangerous for women. So you have a woman coming in saying, I have almost every symptom of X condition,
Correct.
and you're saying, because you don't have this one thing, I am going to ignore all those other things you've
Hmm.
told me. I'm not going to believe even my own brain and my own
That's right.
instincts. I'm going to ignore it all. I'm not going to believe you, and I'm going, or believe you, but put those down to something else,
Yep.
maybe anxiety or depression. And I'm then going to start putting band-aids on you, giving you anti-anxiety medicines, antidepressants. And some women do need those things.
Yeah.
But in general, at this age, with all those symptoms, it's our hormones.
Well, and I think that, and well, the next question I think will be interesting is that your body is full of estrogen receptors. And so when that estrogen is depleting or going into, ups and ups and downs, you're going to have symptoms everywhere, from ringing in your ear to joint pain to weight gain to all of these things, heart palpitations, that are affecting your entire body. So it's, the hot flashes and night sweats are the tip of the iceberg, right? So, and so this leads to the next question, what comes up all the time in our community, which is there a test to tell me that I'm in perimenopause, Dr. O'Sullivan?
There's a test in that there's a questionnaire,
Yep.
which is all I need. It's called, the first one was called the Green Climacteric Scale,
Mm-hmm.
and everything is kind of based off that. And there's about 23 questions, and you can answer 0, 1, 2, or 3. That's your severity. And then your total score could be 69, you know,
Mm-hmm.
and those go through a lot of the symptoms that you just mentioned there.
Yeah.
So many of these are brain symptoms, right? The
Right.
vasomotor symptoms, night sweats, hot flashes, they're from your brain, the hypothalamus, your temperature control center. Anxiety, depression, brain. Mood, irritability,
Rage.
rage, brain. All the brain fog, poor focus, memory, concentration.
Yeah.
Women who have dealt with undiagnosed ADHD their whole lives, keeping it together with post-it notes and reminders
What are you
and
talking about?
having a home for everything, and then everything
Goes
falls apart when our
sideways. Yeah.
hormones. Yeah.
One of the most amazing language changes that I've started to really resonated with me, and I've been telling it to anybody that who will listen. So here we go. Is that for so long we have thought about our ovaries as reproductive organs, right? Oh, these are my reproductive organs. But if you pivot that language to saying my ovaries are endocrine organs, it totally changes how you approach those two little, lima bean size, organs, that they're not just reproductive organs. They're controlling your brain, which is really, really complicated. And so, you know, for everybody who's listening, it's not, you're not crazy. You are not crazy. And there's not a single test that can tell you that you're in this. It's not a cholesterol test. It's not a mammogram. It's not a colonoscopy, where we're so used to being told, okay, or a pregnancy test, like, okay, I'm pregnant, and you get it. And that's just not how it works. And so I think one of the questions that, again, comes up a lot, and this is something that, we would love your perspective on, Dr. Sullivan, is what if I go to my doctor and they just tell me this is normal? All your symptoms are totally normal. Just move along.
So I think, the Women's Health Initiative study that was stopped in 2002, which is where all this fear came from.
Right.
They made a big press announcement and put it in a medical journal and everything, that hormones, they specifically said, I think, estrogen causes breast cancer. So that is where everything starts. And so I think when you go in to see your
Yeah.
clinician, that may be all they remember about hormone treatment and menopause. And so when you go into them and you say, I would like to do a trial of
Mm-hmm.
hormones, I've done my research, I know what's going on, I know what's going to fix me, can you help me? And they say no, that's a mixture of things, right? That
Right.
is fear and lack of knowledge and training.
That's right.
Doctors are not trained in this at all.
Right.
So it's those fear and ignorance. And then also a lot of paternalism
Yeah.
and sexism, right? Because if a man came into me, I feel like I'm different than an OBGYN. OBGYNs only see women. And I feel like you can, that can happen to you a lot without you realizing you're doing it to patients. But then when you're a doctor who sees women and men,
Right.
you see this glaring difference between how you treat your patients.
That's right.
And you're sitting there going, well, why did I act that way with my male patient when he came in and said he was having difficulty with getting erections and his libido was very low and he wasn't feeling great, didn't
Right.
have much energy, he was going to the gym and not seeing any results. Why was I so ready to help him with his hormones?
That's right.
And yet my female patient came in and I sent her off with an antidepressant and didn't believe her.
That's right.
So I think, you know, that's why patients are leaving their doctor's offices so upset because of this lack of
Yeah.
training
Well,
within our
and
community.
I think that it's so pervasive, right? It starts with research, it starts with policies, it starts with protections for women. And then it cascades down into when you're in your physician's office. Fundamentally, they haven't been trained, they don't have the research, and they haven't been embraced by an entire medical system that hasn't prioritized women. So actually, as a follow-up, I think what we will do at HotPause Health is just put some of those statistics in, which every time I read them, my mind is blown. And I walk around the house and I have 4 boys and I tell them all that women's health is a priority in this country. So I think what we will do is we will at least illuminate that and showcase
Good.
that disparity because it's a really big deal. And I think you touched upon the Women's Health Initiative that ended in 2002 because of fundamentally, we now know, incorrect information and fundamentally incorrect assessment of the overall study. And so when a patient comes into you and says, is menopause hormone therapy safe for me? What is your answer?
Uh, Overwhelmingly for most women, yes.
Okay.
Yes. If a woman is actively going through breast cancer treatment or any cancer that has kind of a hormonal component to
Mm-hmm.
it, then
Okay.
you're probably not going to start them on hormones when they're going through their
Because it's a
treatment, you know, because
contraindication.
sometimes,
It's a major
yeah, sometimes the
contraindication. Right.
treatment is actually to block estrogen receptors because estrogen is so good at making things grow. It doesn't create things like cancer,
Right.
but you know, almost like you said earlier, almost every single cell in our body has estrogen receptors.
Yeah.
And they are there for a reason. And they work in tandem with progesterone and testosterone. And they all kind of have a little job to do. And estrogen might love growing things, and progesterone then will keep it in check.
Right.
You know, things like that. And the same with
They all
testosterone.
work together.
They
Yeah.
all work together. We are finely, I often say to my patients, we're like little Ferraris, like we are finely tuned machines, you know?
Yes. Yeah.
And you have to do a lot of tinkering under the hood to get things back to the way you want them to be.
Yeah.
So, I've, yeah, I've forgotten
So
where
the
we were
answer, no,
going
well,
with
the
that.
answer I think is the answer is, and again, and Dr. Sophia, again, thank you for pointing this out. The book Estrogen Matters is amazing. If you want some light reading, just, just pop that out at the beach. There's so much misinformation. And fundamentally, I want to say it was somewhere in the, 40% of women in this country were
Yeah.
on hormone replacement therapy in 2002. And that dropped. It literally was a cliff overnight. And today I've heard everything range from, 4%. And I think the most recent came out was around 1.8 or something in terms of women who are being prescribed hormone replacement therapy, also called menopause hormone therapy. We have some language things back and forth here, but it's plummeted is the net of that conversation. And when you look at the positive impact, often all mortality impact, whether it's cardiovascular health or osteoporosis or brain health, that hormone therapy could have, again, we need more research. There's no question that we don't have all of the answers. And so we need to do a lot more investing in women's health for that research. But research takes 17 years from day one to when you have final clinical results. It's 17 years. I don't have 17 years personally. So how do we make informed extrapolated, really thoughtful decisions on what we have today. And I think what we're hearing you say is for most women, menopause hormone therapy is an option. So definitely talk to your
Absolutely.
provider.
Yeah. Dr. Corinne Men is wonderful. She coined the phrase, we are trying to make perfect decisions with imperfect information.
Yeah. Yeah. Well,
Yeah.
we're all imperfect. I mean, there's no, again, my background is in a lot of prevention and wellness and proactive prevention. And there's never going to be a perfect study that says women born in June with green eyes don't have, it's like we can't do that. So how do we take what we have and make really informed decisions best we can? Which is my next question. And I get this all the time. We get this all the time in the community is if my family has a history of breast cancer, is it still an option for me to explore menopause hormone therapy?
There is no family history that is a contraindication to using hormones. None.
Zero.
None. And even if I have genetic testing and my doctor tells me I am BRCA1, BRCA2, Lynch syndrome positive genetically,
Yep.
and I decide to at some point in my life have risk reduction surgery to reduce my risk of ovarian cancer. And so I have an operation to remove my ovaries.
Yep.
I should leave that operating room with an estrogen patch on my butt.
Slapped on.
Yeah.
Yeah.
Yeah. And, the research that we have shows that using hormone replacement therapy, when you take a woman's ovaries out for non-cancerous reasons, so I didn't have ovarian cancer, and even some of those patients are safe to take hormones, then you should replace their hormones at least until the age of natural menopause in America,
51.
which is like 51. Yeah, exactly.
Yep.
And I just find that so many clinicians do not know that. And I have so many patients who have had risk reduction surgery and no conversation about what was going to happen to them, their brain, their body, their bones, their heart, their mood, their relationship, it's horrendous.
It's staggering. And I think that actually I'm going to pause here and say, obviously reach out to Dr. O'Sullivan and we will put all of her contact information and it's a follow-up. And she'll tell you how to connect with her. But also on HotPause Health, if you are in any state in this country, we have the largest directory of menopause-specific providers. And that ranges from OBGYNs who are menopause certified practitioners to dermatologists, to mental health professionals, to functional medicine, to sleep medicine, to Chinese acupuncturists. Like, it's going to be a yes and, I think, for a lot of women. I mean, of course, you can have your OBGYN, but there are a lot of things that you might have. I mean, again, particularly mental health. If you want to go find someone to help support this really, really impactful transition in your life, there is help for you. So go to hotpausehealth.com and go into our provider directory. Dr. O'Sullivan is there. And so just there is help out there for you. Okay, last couple of questions here that I have. And this one I love because it's so juicy, is testosterone. Testosterone's getting a lot of air coverage, which I'm so excited about. And as a treatment, we would love to hear your perspective on testosterone as a treatment for some of the symptoms of perimenopause and menopause.
Yeah. So to start at the beginning, we are not taught that testosterone is a female hormone, right? Right from the beginning, we're all taught testosterone is a man's hormone, estrogen's a woman's hormone. Right. Not true. So the way it works in our bodies is that our ovaries produce testosterone. And that testosterone then gets converted in a different part of the ovary to estradiol. And so all the estradiol we have comes from testosterone. So for anyone to look you in the face and tell you that testosterone is not important, that's really
is that a myth busting?
ill-informed.
Are we myth busting them?
We're myth busting, yeah. That's just someone being ill-informed.
Yeah.
So in general, if I have a patient who comes to me, has a whole bunch of symptoms, I always say to them, 100% of these could be from your hormones. Maybe 30% of them are from your hormones, but we have an easy and safe way to figure it out. We put
Right.
you on a trial of hormones, and then you follow up with me and we see what's changed, and then we go from there. And so I would say for the majority of my patients, they feel better when we get their estrogen and the progesterone kind of back into their,
Balanced. Yep.
yeah, yeah. And then there will be some women who, everything's not controlled. So we've gone up on the estrogen dose, and they follow up and they say, I didn't notice any benefits between this higher dose and the lower dose I was on last time. And so we put them back on the lower dose. And then that's usually when I say, testosterone may be um, a good choice for you now that you still have these other symptoms. And what the other symptoms are a lot of the time for a lot of women
what
is,
are those things for testosterone that specifically address,
yeah,
some of the crucial symptoms?
and they overlap with the symptoms for estrogen too, right? And estrogen usually fixes these, but in some women it doesn't. So it is confusing. So I would say fatigue, poor stamina, especially if you're trying to weight train and you feel like you're just not able to
Right.
make progress.
Too hard. Yeah.
Yeah, you're not able to build muscle.
Yeah.
And some of that, of course, can be dietary and other things as well, but just to keep it like really simple. And then for some women as well, low libido.
Yeah.
And so those, and focus, concentration, memory tends to come up a lot as well.
Yeah.
And so if I am starting a woman on testosterone, there's a few things that we talk about first. Firstly, I'm giving it through the skin. So it's not going through the liver.
Transdermally.
It's not,
Yep.
yeah, it's not going through the liver or first pass metabolism, and it's not affecting your clotting factors or anything like that. We're using really teeny tiny doses. And we are always aiming to keep you in what we would think of as a normal physiologic range.
Right.
So we're not aiming for super physiologic levels where a man might be. Because although throughout our lives we have 5, 6, 7, 8, 9, 10 times more testosterone in us than estrogen at any time during our reproductive lives, it's still only about a tenth of what a man's level is,
Right.
So we're always aiming to keep you in that kind of female level.
Right.
And when you do that, you're not going to get these side effects that we hear about when people say they're scared of testosterone. So if I treat you with something, say like a testosterone pellet, your testosterone might go up to 300-400, which is now in the male range.
Right.
And you may, sometimes women will develop a change in their voice, a deepening of the voice, which is not reversible, or clitoromegaly, which is enlargement of the clitoris.
Right.
And that is also irreversible. And
Yep.
so you just are very careful and you keep an eye on the blood work. And it's always really important if you're on testosterone to be keeping your follow-up appointments with your doctor,
Yeah.
And then I always say when I'm starting it as well, you really have to commit to about 6 months, because sometimes it works really, really slowly. And you'll meet a lot of women who'll say, oh my God, it was only in month 4 or month 5 or
Did
month
something
6
happen?
that I noticed
Right.
it.
Right.
Yeah.
Yeah.
And so trying it for a couple of months, not getting any side effects, but not noticing any benefit is not the answer. You either commit to 6 months, I think, or don't bother.
Right.
And then I think at 6 months, when you follow up, you will know, yes, I've noticed all these benefits, I want to stay on it, or no, I haven't noticed anything, and then I just stop it.
Right.
You know?
So I want to punctuate 3 things because I think it's really important. Number 1, that testosterone in our bodies is part of the female balance of hormones. It is not a male hormone. So at any given time, we can have 10 times as much testosterone as estrogen in a given part of our cycle. So that's number 1. We've gendered hormones. So let's try and reverse that. Number 2, the testosterone is not just about low libido. It's actually for brain function, fatigue, fog, clarity. And some of the things that we've heard is that when women go on testosterone, they go back to their provider and say, I'm seeing in color again. That something just is this radiating clarity and color and vibrancy that they haven't had for so long. And Dr. Sophia Yen, you pointed this out, and this is a really important conversation, is that testosterone is not FDA regulated, or not, it's regulated, but not for women. So it is off label. There is no prescription that a woman could go to and get their doctor, and it's for women, dosed for women, provided for women. It is off prescribed. Dr. Sullivan, you can speak to
off
this.
Label.
Off label.
Yeah.
And so I think hopefully there will be legislation, policy, and a revisiting of testosterone soon. Fingers crossed. But I would love for you to talk about that just very briefly, just so that people understand.
So yeah, Australia has a product for women, Androfem. It's specifically for women, and now you can get it in the UK as well, privately. But we do not have a product over here, and so we have to use the men's testosterone. And in general, it's called a gel. It comes in two forms. Well, it comes in a few forms, but I'll just talk about the test gel. So it comes in a tube with a cap on it, and it comes in a little packet, like a ketchup packet. Right. Yeah. And so if you've ever had the ketchup packet and opened it, you will see it is not a gel. It is a liquid.
Yeah, it spills everywhere.
A liquid. Yeah. And so a man would open that tube or that packet and empty the whole thing into his hands and rub it all over his arms and shoulders and let it air dry. He would use one a day. Whereas a woman is supposed to make one of those last 10 to 14 days. And that is really difficult if the pharmacist gives you the packets. Right. And even though I write on every single prescription I've ever written, please only dispense tubes with caps, I have very few patients who've been dispensed the tubes. They all are given the packets. And so we have workarounds for that. You know, there are little click pens that you can put a few packets into, seal it up, and then you use a click a day, a click or two, whatever it works out to be. You can pull it up into a 5cc syringe and use a half a cc a day. Or if you get the tubes with the top, at least then that is actually a gel. Right. And you can use like a little pea-size amount a day. Right. So, but
I think this is all to say that women do not have access currently to a testosterone product treatment meant for women. So you will have to talk to your provider. Exactly what Dr. O'Sullivan just said. The way that she's going through and having these conversations with her patients is very nuanced, and it really takes, I would say, a level of education that is robust. And so if it's something that you do want to talk about, certainly reach out to your provider and see if they offer this, but it is not currently prescribed in this country in the way that it is for men. So, okay, with that, we are at time, but I do want to say, will you just tell everybody who's listening how they can get in touch with you if they are in Oregon or Washington or Connecticut and schedule an appointment?
Yes. First of all, follow me on Instagram. I'm Portland Menopause Doc. And then I have a website as well, www.portlandmenopausedoc.com.
And yeah, we'll put all this information, but just in case you're on right now. And but we're so grateful. Thank you, Dr. O'Sullivan, for being on this morning. We love talking to you. We would talk to you all day.
I could talk to you all day. I could talk about menopause all day. I love it.
It's a problem. It's everywhere I go. It doesn't matter where I am. I'm like, hey, do you want to talk about menopause? Because I do.
I
know. Anyway, so thank you so much. And we're so grateful for you. Thank you for everything you're doing for women's health.
My pleasure. Likewise. Thank you for everything you're doing.
Okay. Well, we'll be in touch soon.
Okay.
Thanks, everybody.
Bye.
Bye.